I'm going to start out just with talking about why sleep matters. So when we think about sleep, sometimes people tend to take it for granted and even have this idea that it's like almost a badge of honor if you don't need sleep. Like, oh, I don't need sleep, or sleep is for, when I get older, or, something else like that. But when we're talking about insomnia, it's really not something to be pushed aside. When people have insomnia or other sleep disruptions, it can actually make a lot of other areas of your life worse. So not only physical well-being, but also mental health symptoms. So these include things like pain, fatigue, anxiety, and depression. So probably people can understand that there's a bit of a vicious circle with all of these comorbid symptoms. So, when you're not sleeping well, it lowers your pain threshold, which increases your pain and makes it more difficult to sleep. So, that can exacerbate one another. Same thing with fatigue, right? So if you're not sleeping well, you may have higher levels of fatigue during the day. The levels of fatigue that you're having prevent you from doing things that would increase your energy or maybe make you take naps during the middle of the afternoon, which again, make it more difficult for you to fall asleep. And people who have had nights where they're not sleeping very well can understand why their mood is impacted. So, maybe you're a little bit more short-tempered, maybe you're, just not as interested in things that you would normally be. So symptoms of anxiety and depression can also be worse. We also know, based on some Canadian research, that people with insomnia symptoms actually had an increased risk of infections. So we know from experimental research that sleep definitely has an immune enhancing impact. There was actually a really, really cool study that showed that if you take healthy young men and you sleep deprive half of them, you randomize them and you sleep deprive half of them and stick them in a hotel, and you let the other half of them sleep as well as they want in the hotel, and then you expose them to a cold virus. You basically shoot a cold virus up their nose. The people that didn't sleep as well were way more likely to get or express symptoms of the cold virus than the people who were able to sleep. So there is the immune enhancing impact of sleep as well. And it doesn't seem to be short term, right? Like there is a recovery when you have a short term amount of sleep disruption where, your body has this amazing sort of homeostatic mechanism, like less is followed by more. So it ultimately balances out. But when there's more bad days than there are good days, that's when it can take a toll on your symptom or like on your quality of life. And this impact really can be durable. So it can contribute to overall poor quality of life 10 years post-diagnosis. So we know that good sleep quality, and when we're talking about good sleep quality, we're talking about people who aren't concerned about their sleep, they don't have any sleep complaints, and they also have consolidated sleep. And when I talk about consolidated sleep, I mean, when we have solid chunks of sleep that aren't characterized by frequent awakenings. And one of the tools that we use to measure sleep is actigraphy, which is basically like a bit of a research grade sleep watch. We know that overall, that sort of good quality sleep is actually characterized by a reduction in overall mortality. And this was a study that was conducted in women with metastatic breast cancer. So this is some research specifically that has been conducted in people who have been diagnosed with cancer. But when we look at the general population, we also know that impaired sleep is related to problems with cognition and memory. There was some really cool sleep that came out in the last 10 years that actually showed that when we sleep, our brain actually shrinks. So there's a greater amount of room in our brain for the cleansing of our brain by the interstitial fluid that goes around the neurons. So it actually washes away all of the byproducts of the activity of our brain during the day. And so, the headlines in the news, this was really promoted as basically sleep gives your brain a bath. And the proteins that it was washing away were proteins that were associated with buildup of those specific proteins that are associated with dementias. So we know that impaired sleep is related to problems with cognition and memory. It does increase your risk of other medical conditions. So it impacts metabolism, which can lead to problems with obesity, diabetes, and heart disease. We know that in people who have depression and anxiety already, if they treat their depression or anxiety, but they don't treat their sleep, it can actually lead to an increased risk of depressive or anxiety relapse. So it worsens recovery from these psychological disorders. So, that's more physical and emotional health, but it can also impact your pocketbook. So people who don't sleep well, they have more increased healthcare costs, and they spend more days out of work, which you can understand if you haven't had a good night's sleep. Probably the first thing you're thinking about the next morning is, how can I get out of the work that I have to do, because I completely feel awful. So when we're talking about sleep, before I get into the sleep disorders, I want to explain a little bit about how sleep works, because this is pretty important when we think about how other interventions work to improve sleep. So I'm going to diverge a little bit and explain about sleep stages and states. So we might have some neurologists in the group, we might have some other people, but for the people who aren't neurologists, we actually sleep in two particular states. So we have non-REM sleep, and this includes 3 stages. So let me see here. We have non-REM and we have REM. Now, do you see my little cursor? Yeah, okay, perfect. All right, so the 3 non-REM stages right here are stages 1, stages 2, and stages 3 and 4. And the waves that you're seeing are actually electricity, right? So it's the electricity that's going on in our brain. And when we're awake, these electricity in our brain is actually very tight, very coiled together. So you can see here, when we're relaxed wakefulness, these waves, these brain waves, are very tight and very small in amplitude. When we start going into stage 1 sleep, which is the stage of sleep that is our lightest stage of sleep, you can see that these brain waves start to kind of like get bigger, and they start to spread apart a little bit more. These are called characterized by theta waves. And so stage 1, we don't spend too much time in stage 1, but as we age, the amount of time spent in stage 1 increases. And in stage 1, this is where people might experience what's called hypnic jerks, right? So people who might feel like they're kind of falling and then like jerk themselves back awake, right? So if you're experiencing that, you're in stage 1. Stage 1, you can actually be pretty easily aroused if somebody, calls your name or bumps you or something like that. So stage 2 sleep is deeper sleep, and we have a higher arousal threshold, meaning that it takes a little bit more to wake us up. And this is stage 2 sleep. And stage 2 sleep is characterized by these sort of like pockets of really consolidated sleep and these big waves here. And stage 2 sleep, we actually spend about 50% of our night in stage 2 sleep. And then that sort of transitions us into what is called slow wave sleep, or stages 3 and 4 sleep. This is our deepest stage of sleep here. And so you can see the waves of our brain are really big and really far apart. This is the stage of sleep that does most of the repair and restoration for our body. And if you were to try and wake somebody up from this slow wave deep sleep, this delta sleep, it would be really, really hard to wake them up. And if you woke up out of this deep sleep, you might experience some temporary kind of like confusion or grogginess, who am I, where am I, who are you, all of this kind of thing, right? Kids get a ton of deep sleep. This is why, you can pick them up from under the table at a party, put them over your shoulder, put them in the car, and then get them home and put them in their bed by the time they actually wake up, right? They spend a lot of time in stage 3 and 4 because, like I said, it's associated with more of the repair and restoration features. So now then, the last one here is REM sleep. So all of these were non-REM stages. The last one is REM sleep. REM sleep is really, really interesting because what happens during REM sleep is we experience muscle atonia, which means that our bodies are actually paralyzed during this stage of sleep. So we're not able to move our major muscle groups. This does have, this is hypothesized to have this protective effect that, we aren't able to act out our dreams, right? So because the dreams that we can have during REM sleep can be very vivid, right? People will, leap across buildings, or, run marathons, or chase bears, or whatever their dream might be. And so if we had the ability to move our major muscle groups during that time, it might be a little problematic for us. So having our body actually shut off our ability to move our major muscle groups during this REM sleep can be protective. During REM sleep also, it's characterized by particular eye movements, so our eyes actually move in opposite to each other, and certain areas of our brain actually light up. So the amygdala, the area of our brain that is more associated with emotion, is part of the brain that's really active during this time. And REM is also very important for consolidation of memory. So this is why you can have these dreams that make no sense, but have a very strong emotional content to them. You can also notice that the waves of your brain when you're in REM sleep are very similar to when you're awake, right? They're very, very low in amplitude and very, very close together. And then what happens is we actually cycle through these sleep stages during the night. And each cycle of sleep usually takes about 90 minutes or so. So you'll see here, we've got being awake, and then this is REM sleep. And then we go down through the sleep stages 1, 2, and then 3 and 4 here, both together are your deep sleep. And it takes about 90 minutes, like I said, for you to get down into deep sleep and back up. So here's about your first 90-minute threshold. So, we might spend a little bit of time here at the beginning of the night being awake. We bypass REM, and then we spend a little bit of time in stage 1 sleep, a little bit more time in stage 2 sleep, and then we go down and we spend usually quite a long period of our first sleep period is spent in slow wave sleep. And then we cycle back up, have a little brief REM episode there, bypass sleep stage 1, have some more 2, and then 3 and 4, come back up, have a little bit more REM. We might have an awakening here. For most people, that first awakening happens about 3 o'clock in the morning, right? So we might wake up a little bit, and then again spend some more time in stage 1 and 2, come back up, have more REM. Stage 1, 2, have another little awakening, maybe turn over, switch our body position, more REM, more stage 2, and then wake up. So this is sort of like the typical sort of architecture. What isn't captured here is that it's normal for lots of people to have more than one awakening, right? We are always cycling through our sleep stages, right? So there's going to be periods during the night where we're more difficult to wake up when we're in our deeper sleep. And then there's going to be periods when we're more easy to wake up. And usually those periods when we're easier to wake up are going to be close in proximity to when we would have been in REM sleep. Because as I showed on the previous slide, our brain waves, it's easier for us to transition from REM sleep to being awake because the brain waves are so similar. If you were to try and wake up when you've been close to one of these slow wave sleep episodes, it would make you groggy. You wouldn't feel very good waking up out of it. That actually has to do with one of the reasons why people recommend that you don't want to nap for too long, because if you nap for more than about 30 minutes or so, you're getting into this deep sleep stage. And that's why sometimes these longer naps can actually make you feel worse, because you're getting into the groggy sleep where you haven't had the recovery that comes with a longer sleep period. So if I put a little kind of benchmark, kind of halfway in the middle of your sleep, your night of sleep, there's a big difference happening between the first part of the sleep episode and the last part. The first part of the night is characterized by more of that deep sleep, that stage 3 and 4 sleep. We get more of that delta slow wave sleep, that sleep that is associated with the repair and restoration of our body. That tends to happen more in the first half of the night. And we get more of our REM sleep, and the REM sleep is associated with more of the emotional regulation and the memory and the cognitive factors. So it's more like physical stuff is going on in the first half of the night, and more of the emotional and the cognitive stuff is happening at the last part of the night. So this is, I think, interesting. And, if you think about why we might want to have these sort of cycling through our stages of sleep, you may actually want to have periods in the night that you're more likely to be easier to wake up. So for example, if we needed to attend to some sort of emergency in our environment, if we were like completely out in like really, really deep sleep, it wouldn't be easy for kids to wake us up to tell us, that we need to attend to them. If we heard something outside our house, like our arousal threshold is very, very high. So it would take a lot to arouse us from slow wave sleep. So these periods of having more ability to be woken up allows us to attend to our external environment. It also allows us to attend to our internal environment. So if we need to go to the bathroom, if we need to change body positions because we're a little bit sore or something like that, that's why we have these stages in our sleep that we're easier to wake up. I think about Paleolithic times or something like that, everybody sleeping in the cave, you want to have periods where you're more likely to hear that saber-toothed tiger or something like that, right? So to make us a little bit more easy to wake up. Now, our sleep quality does change as we age. This is the most depressing slide that I think that I'm going to present to everybody, because people say, I don't sleep quite the same as I did when I was younger. And that is true. And there's a biological reason for that. So on this line here, I've got total time in minutes of sleep. And then I've got age kind of going from, kids all the way to, mid 70s, right? And so what you see is that, the younger you are, the more of this delta sleep, this slow wave, this restorative sleep, you see that going down. You get a lot of that slow wave sleep when you're kids, as I mentioned, because that is the type of sleep that is associated with the repair and the restoration. So kids, when they fall down, they just basically, they're rubber, right? They bounce back up and they heal just like that, right? So part of that has to do with, they get a lot of this slow wave sleep. And as we age, the amount of time that we spend in that slow wave deep sleep, that does go down. That is also why it takes us a little bit longer to bounce back than it did when we were younger. The amount of time that we spend in stage 2 sleep once we reach adulthood, that stays relatively constant. Same thing with REM, that stays relatively constant. That's why we can still, even though our bodies might fail us in ways that they didn't when we were younger, cognitively, we can still be pretty quick. The amount of time we spend in that light stage, this stage 1 sleep, that does tend to increase. So we have periods in the night, longer periods in the night, that we're able to be aroused easier. But then what really spikes is the amount of time we spend awake in bed. That tends to start going up. So we're spending more time awake in bed when we didn't when we were younger. So when I talk about insomnia, and I threw that word out there earlier, what I'm really talking about is I'm talking about a dissatisfaction with sleep quality or quantity characterized by 3 major things. So one of them is difficulty falling asleep. And this isn't just, 10, 15 minutes. When I talk about difficulty falling asleep, if it's exceeding 30 minutes from when you go to bed, close your eyes, and sort of intend to fall asleep, if it's getting to be more than 30 minutes, that's the threshold for where I would say, okay, that's too much. Same thing if you're waking up in the middle of the night and you're awake and it's taking you more than 30 minutes to fall back asleep, that's getting into the problematic range. And if you're finding that you're waking up earlier than you want to wake up and you can't fall back asleep, all of those things, if you're exceeding that 30-minute threshold, that could be concerning, that insomnia might be present. And at least if this causes significant impairment in daytime functioning or distress. So if people are finding that because of these sleep disturbances, they're not able to do what they want to do, it's causing them some problems. And it needs to occur more often than not. So at least 3 nights per week, despite adequate opportunity. For at least 3 months. That's when we would consider it not to be acute or temporary or transient. So if it's occurring more nights than it's not occurring and it's been ongoing for at least 3 months, that's when you're more likely to meet the diagnostic criteria for something called insomnia disorder. So this is often accompanied by impairments in daytime functioning, which are often reduced cognitive capacity, fatigue, mood disturbances, and whatnot. So when we think about specifically sleep in people who have been diagnosed with cancer, the research early on suggested that about 30 to 50% of people who have been diagnosed with cancer would report sleep quality issues or difficulties. But the research that was conducted had some methodological limitations. So they were cross-sectional, meaning that, just taking like people at one time, and they often had small samples. The measurements that they were using of sleep weren't exactly great. And oftentimes sleep was being assessed, way after they had completed cancer treatment. So they really didn't provide us enough information to really look at sleep during the cancer experience. So we wanted to know from the research that, like, what was the incidence? Like, when did these sleep problems start? How many people recovered from these sleep problems? And then in how many people did these sleep problems continue? So this was the best study. It was conducted by some colleagues of mine in Quebec. So I'm really proud that it's Canadian research. They actually surveyed close to 1,000 patients at the time when they were awaiting surgery. And they had, the group was really, really wide. So they were looking at all cancer types. And so they were assessed during this perioperative phase. And then again at 2 months, 6 months, 10 months, 14 months, and 18 months later. And then they actually used a really good methodology. They used interviews. So they interviewed close to 1,000 people. And then they characterized them into either good sleepers. So these people didn't have any problems, and they weren't using sleeping medication, or people who had symptoms of insomnia. And so then these symptoms caused some concern, but they weren't actually at that threshold, or they didn't occur frequently enough to be considered an insomnia syndrome. And then those people who had the insomnia syndrome, these were people who were experiencing problems 3+ nights per week, or were using sleeping medication to manage them. So what they found is that at baseline, close to 60% had insomnia symptoms. And of those 60%, 28% would actually have met criteria for insomnia disorder. Now, the overall rates of insomnia did decrease over time, but 36% of the sample still had insomnia symptoms when they had this last follow-up at 18 months, and then 21% actually met the criteria for insomnia. So when we think about, all right, well, 20%, that doesn't sound so bad maybe, but it's actually double that of the rate of the general population. So the general population has an insomnia rate of about 10%. So those people who came in with insomnia disorder, they were the ones that had the hardest time, because it was a really, really persistent condition, with rates of anywhere from 69 to 80% of people who came in with insomnia, they just stayed having insomnia. So this really suggests that without intervention, this doesn't go away on its own. So I wanted to show you this. And so we can actually see the people who came in with prostate cancer overall, and I know this from my clinical work and my research work, compared to other patient groups, men with prostate cancer do tend to report lower levels of insomnia than other cancer groups, but they still are well above that of the general population here. So that's that line that I'm saying. So when we look at the little striped bars here, these are the ones that would actually meet the criteria for insomnia disorder, which is the more severe, significant problems with sleeping. And then the people who have the solid color bar, this is the people who have insomnia symptoms. So it is a significant problem in people during their treatment for prostate cancer, and also at least up until 18 months after their diagnosis. So why is this more common? Why is it double the rate in people who have been diagnosed with cancer than the general population? And probably, just a little bit of thought, it's not hard to understand that a cancer diagnosis is also associated with an increase in anxiety and depression, which is associated with difficulty sleeping. We know for people who are treated with chemotherapy, that treatment itself disrupts circadian rhythms. And when I say circadian rhythms, I just talk about sleep and wake patterns. The medications that people are on, especially any of the corticosteroid medications, those directly cause agitation and disrupt sleep. I often talk to people and I say, like, were you warned by your treatment team that this medication would keep you awake at night? And most people say no, they weren't. They find it really, really distressing when they try and fall asleep after taking these medications for some time and their mind is just racing. They can't get to sleep. So both in men and women, hormonal treatments can cause and worsen hot flashes. And then other things, getting up in the middle of the night to go to the bathroom, pain, discomfort, and fatigue. Those are all reasons why we see insomnia being more common in people who have experienced cancer than the general population. So, skip over that because I said it already. When we think about what is recommended for the treatment of insomnia, and if I were to poll this group right now, which I know is a function, but I'm not going to do it. If I were to poll the group to say, all right, what is the best treatment for insomnia? I don't think your answer to me would be something along the lines of, oh, well, they should go see a psychologist and get cognitive behavior therapy for insomnia. Most of the time, people might say, oh, well, sleeping medications, or maybe you should exercise more, or, something else like that. But we've known for some time that, like, at least since 1998, the evidence has suggested that psychological and behavioral interventions are the best interventions for insomnia. So this is just in the general population. This was the first one published in 2006 to recommend cognitive behavior therapy for the treatment of insomnia. This was updated. Oops, sorry, I'm going backwards. This was updated again in a practice report. And then also we've got a clinical guideline here for the evaluation and management of chronic insomnia in adults. This was actually even strengthened, this recommendation for cognitive behavior therapy for insomnia, with this practice guideline that actually encouraged physicians to say that the American College of Physicians recommends that all adult patients receive cognitive behavior therapy for insomnia as the initial treatment for chronic insomnia disorder. This was huge because it's the group of physicians in the United States saying that we're actually recommending that people receive this treatment as a first-line treatment. Second recommendation is that people should use a shared decision-making approach. So discussing with patients the benefits, harms, and costs of using medication short-term to decide whether or not to add medications onto treatment for people in whom cognitive behavior therapy alone was unsuccessful. So this was a really, really big deal. And so this is not specific to cancer, but we also have a great deal of evidence that this is the best treatment in cancer. And that's what largely my research has been focused on. So this was one of the first ones here. This was in 2009. There was a recommendation here in this paper on sleep-wake disturbances in adult patients with cancer. This one was a review that I conducted, and it was a systematic review of cognitive behavior therapy for patients with insomnia. This one, again, came out of Canada with myself and other researchers to basically say this is the best practices for assessment of management of sleep disturbances in adults with cancer. And then this is the latest one here in the Clinical Journal of Oncology Nursing to look at evidence-based interventions for sleep problems. So, even to strengthen this a bit more, this is the guiding organization in the United States that says, this is how problems should be treated by clinicians. And they actually recommend for people who have insomnia symptoms that CBT is actually the preferred intervention over sleeping medications as a first-line therapy. So now that I've kind of hit you with all of these like practice parameters, research recommendations, clinical guidelines, and everything else like that, that recommend this treatment, I bet you guys are all thinking like, I don't know what she's talking about. What is this treatment, right? So here, Cognitive behavior therapy for insomnia, as in the title, it deals both with sort of thoughts and behaviors. So here's a little image that you can get an idea what these behaviors might be like, right? So here's this guy, he says, I spend all day hunched over a desk, railing coffee, staring at a glowing screen, and then reading the news. And for some reason, when the sun sets, I can't seamlessly transition into calming down enough to fall unconscious. Right? So we know that sleep is impacted by behaviors that we do during the day, right? We know that. Some people aren't aware that certain behaviors can be more problematic than others, right? So this intervention does deal with behavior change, but it also does a lot to do with the way we think about things, especially sleep. So says, I do a lot of thinking before I go to sleep. I play scenes in my head. I practice the things I want to say. I have endless what ifs. I make plans for the next day. I think of all the people I miss. I think of all the ones I hate. I ask myself a lot of questions, right? So, the experience of insomnia in people is that, like, they could be just falling asleep, completely like nodding off on the couch, and then they think to themselves, yes, perfect, I am going to fall asleep, great. And then they go upstairs to bed, and all of a sudden, they're wide awake and their mind is racing and they're thinking about things, right? So that sort of like arousal that happens in bed is one of the key signs that it's insomnia. So one of the things that is important to know about sleep is that it is controlled by something called sleep drive. So sleep drive is a very sort of like, I think it's brilliantly simple, because basically what happens is our sleep drive or our sleep pressure increases during the day from the time we wake up. And it's actually controlled by a neuromodulator called adenosine. And adenosine accumulates in the brain during waking hours. Interestingly, caffeine actually works on this neuromodulator called adenosine. So it binds to the neuromodulator adenosine, which prevents this sort of like noticing of the buildup for, about anywhere from 4 to 6 hours until its effect starts to wear off, which is why caffeine actually promotes alertness in the short term. So this is the mechanism that it works on. And then what happens is it continues to build, we sleep, and then it decreases during the night, and then this whole process starts again. So this sleep drive is sort of, again, that homeostatic mechanism that less is followed by more. So what happens is when people are diagnosed with cancer is this sleep drive starts to be impacted, because what determines when your sleep drive starts building is the time you wake up. So let's say if I am a 7-hour sleeper and I wake up at 7 o'clock, I'm going to need 17 hours of sleep pressure to build before I'm likely to fall asleep, right? So you can either go forward 17 hours or back 7. So I'm likely to fall asleep at midnight, right? If I'm a 7-hour sleeper and I wake up at 7 o'clock based on sleep drive. But what happens is, let's say people decide I'm going to sleep in because I'm not feeling well, or, I'm off work for a little while or something like that. And I decide I'm going to sleep in until 9. That doesn't really change the amount of sleep I need, but it is going to change when my sleep drive starts accumulating. So it means that I'm not likely to fall asleep until 2 if I wake up at 9. Does that make sense? People nod. Okay, so that morning sleep time, people are often told you should go to bed at the same time every night, right? It's actually backwards. You should wake up at the same time every day, because your wake up time determines your bedtime based on sleep pressure. That's the key that a lot of people are missing, is that if you move your sleep or move your wake up time, you're automatically going to move your bedtime. And then what happens is people don't understand that, and they go to bed at midnight thinking, well, midnight is the time that I always go to bed. But then they find themselves lying awake for 2 hours because they can't fall asleep. So, and then they start to worry about the fact that they haven't fallen asleep, and then that's where the cognition starts to come in. The other thing that influences our sleep is something called circadian rhythm, and I mentioned that earlier before. It's the body's built-in sort of clock, and this clock is really centered in our hypothalamus, and it controls the timing of sleep. And our circadian clock doesn't really care so much about our sleep drive. This is why it makes it really hard, even if we haven't had much sleep at night, for us to sleep during the day, because our circadian clock is promoting alertness. So it tries to coordinate things with the day and light period over approximately 24 hours. The average person's circadian rhythm is about 24.3 hours. Our circadian rhythm also regulates our sleep, our eating, core body temperature, cell regeneration, hormones, everything else. So it's got a very, very important job. When circadian rhythm and sleep drive work well together, they look like this, all right? So we've got 7 o'clock here, we've got 11 o'clock here. This is the period when we're awake. We sleep for 7 hours, or we sleep for 8 hours there, sorry, and then we have our period of wake and sleep. So this is over the period of 48 hours. This is what our circadian rhythm does, is it actually promotes alertness, right? So from the time we wake up in the morning, it's promoting alertness, 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 alertness. And when it's at its lowest period of promoting alertness, you know, that's when our sleep period happens. Now, when we pair that with our sleep drive, we can see that our sleep drive here starts low and then it increases throughout the day. And what happens is when we have the largest gap between our sleep pressure, our sleep drive, and our circadian rhythm, that's when our sleep window opens. And then that's when we have our period of sleep. So when these two mechanisms are operating together, we have the greatest chance of sleep, right? If we were to switch this later, right, what would happen is you might actually fall asleep later, but it doesn't mean you would sleep later, because your circadian rhythm is going to start promoting alertness, right? So you're trying to keep these two mechanisms working in harmony with each other. But what happens is, even if these are working really well together, you can have something override them, and that would be our arousal system. So anytime our mind kicks in, or our emotions kick in, again, here I'm going to show an image to you. It's the person laying in bed, it's 10:30, and the brain is saying, okay, let's revise some of the dumb stuff you said today. This could take a while, right? So she's thinking about things in bed. And then now it's after 11. And the brain's saying, just quickly, you know, the person's about to fall asleep, and the brain says, just quickly, remember that argument from 6 months ago, right? And then here, the brain's going, you know, you're going to be really tired in the morning. So when you have the brain and your thoughts, you know, kind of kicking in there, that can be powerful enough to override how tired we are, and also, you know, where we are in our circadian rhythm. It really allows us that evolutionary adaptive way of being able to respond to emergencies. Whenever like our emotions kick in, it doesn't matter how tired we are, that kind of gets shut off, and it makes it more difficult for us to fall asleep. So there is a process that INSOMNIA develops. It's called the 3P model. So again, I'll orient you here. We've got, this is insomnia severity here on this side, and this is time at the bottom. So premorbid means you've got no problem sleeping. This acute period is, you know, a couple weeks problem. Short term is 2 weeks to 3 months, and then chronic. What happens is that everybody has some predisposing factors that contribute to whether or not they'll develop insomnia. So these premorbid things are these predisposing things are things that don't change. It could be genetics. We could come from a long family of people who don't sleep. It could be age. It could be sex. If you have coexisting medical conditions. But then usually what happens is that there's a precipitating event. So something puts us over the threshold for insomnia. So usually this is a stressful event. It could be, you know, the diagnosis of cancer. It could be a series of stressful events. And in that acute period, that's enough for us to experience problems sleeping. What happens over time, though, is that the impact of that event contributes less and less to our insomnia because we adapt to it. So if it is the diagnosis of cancer that kind of puts somebody over the insomnia threshold, with time we become less and less worried about that initial diagnosis, because we know what our treatment plan is. You know, we're getting used to things. You know, we're adjusting. We adjust, just like we have to COVID, right? We adjust. But what happens is that in the meantime that we're trying to adjust, sometimes we engage in behaviors that actually perpetuate the insomnia, make it more likely that it's going to stick around. These are things like spending more time in bed trying to sleep, right? I think people who have had problems sleeping know that trying to sleep never works. The harder we try, the more difficult sleep becomes. The other thing that people will do is go to bed earlier to give yourself more opportunity to sleep. Again, that doesn't work either, because you just end up spending more time lying awake in bed. Sometimes people will sleep in, trying to recover some of the sleep that they didn't get at night. And now, because I've described what the importance of sleep drive is, we know, again, that doesn't work. Napping during the day is also a perpetuating behavior, because, you know, that's going to take away from that sleep drive and make it more difficult for you to fall asleep. Worrying about the effects of poor sleep is also a perpetuating behavior, because then you get more anxious, and the more anxious, the more performance anxiety you get around sleeping, the harder it is for you to sleep. So eventually, over time, by the time it gets to 3 months, you've had 3 months that has conditioned the bed to be associated with being awake. So if night after night after night, you pair your bed with wakefulness and thinking and planning and things besides sleeping, then you get a situation like this, where it's conditioned arousal. We do it to ourselves in front of the TV, right? Like if we repeatedly pair the television with snacking, it doesn't matter if we have just had a meal or anything like that. As soon as we sit down in our favorite chair, we find ourselves getting a little peckish and we want to sleep, or we want to snack. If we repeatedly pair our bed night after night after night with being awake, this is why you can be falling asleep in your chair, which you don't really pair with being awake, or pair with, you go to bed and you find yourself wide awake because you've paired your bed with being awake instead of being asleep, right? And then what happens is people will go to the couch and then they'll fall asleep immediately on the couch, because their couch isn't conditioned with that sort of stress and wakefulness and thinking and everything else like that. Does that make sense? Yes, good. I like to see some nods here because it's a little different. All right. So there are a couple of other sleep disorders I want to touch on because they're important and they are more prevalent as we get older. The first one is obstructive sleep apnea. And this one is a really serious sleep disorder that a lot of people don't pay enough attention to. And so this is either the partial or full blockage of the airway during night. So people with obstructive sleep apnea have, usually it's their bed partner who says, you know what, you stop breathing at night. So you're having these periods where you snore, and then you stop. And I'm afraid for you because you're not breathing during the middle of the night. So people who have witnessed these apneas, the people who have sleep apnea do tend to be snorers. They wake up in the morning with a headache and a dry mouth. They might experience night sweats. They do tend, in some people, obesity is associated with a higher incidence of obstructive sleep apnea. If people have a narrow airway due to any kind of anatomical or structural differences, if they have a large neck circumference, which is why it's more common for guys to have obstructive sleep apnea than females, is because they do tend to have larger necks, and if they have a recessed jaw. So those are all things that can increase your likelihood of having obstructive sleep apnea. And I'll show you what this looks like on one of those home sleep apnea tests, okay? So this is a test. This is a half an hour of somebody that doesn't have sleep apnea. This is what it would look like, the person who's reading your sleep apnea, home sleep apnea test. So here, if there was a line here, it would mean that the person was supine or laying on their back. If there were any sort of dots here, this would mean that the person was snoring because it's measuring sound. This line going up and down is nasal pressure measured by the nasal cannula. This is heart rate here going across. And this is oxygen saturation going right across here. All right, so this is me. There's my sleep in a half an hour. I don't have sleep apnea. But this is somebody who does. So what happens, you can almost hear this person at night. What happens is that they have, this is nasal pressure and this is snoring, right? So what happens is they're snoring, stop. this is an apnea period right here. So what happens is their heart rate is dropping, their oxygen saturation is dropping, right? And this is only a half an hour period. So if we count here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 15. So it's basically 1 every 2 minutes. This person is having sleep apnea. So you can imagine the damage that that does to, or the challenge that that places your heart, your cardiovascular system, your respiratory system, because basically what's happening is your body is having to work harder to force the airway open. And then the airway closes again, and your body has to force it open. So people who have sleep apnea actually don't get into those deeper sleep stages. They don't get into REM sleep, and they don't get into slow wave sleep, that deeper sleep, because those two sleep stages relax the body's muscles more. And so that's when those apneas are also more likely to occur. So this is why individuals with sleep apnea are really, really sleepy during the day, and they report higher levels of depression, problems with memory, concentration. Overall, this represents a huge cardiovascular risk. So symptoms of sleep apnea are nothing to be taken lightly. The reason people don't pay attention to this is because they don't want the treatment. And they think about this. They think about continuous positive airway pressure, that sleep apnea mask. That is the most effective treatment for sleep apnea. But depending on your type, there may be other things like positional therapy. If you only have these apneas when you're on your back, you can position yourself only on your side. If it has to do with something structural, there are dental devices or surgery. So considering the health risks of it, it is a very, very important thing to get treated. The other thing is restless leg syndrome. This is that creepy, crawly, tingly feeling in your legs, feet, or calves that make it more difficult for you to fall asleep and relax in the evening hours. And this can lead to the development of insomnia because you just can't relax. Restless leg syndrome is worsened by certain medications. So if this is a problem for you, getting that checked out with your pharmacist or with your physician. So, but caffeine, alcohol, antihistamines, and antidepressants are some of the ones that are most likely to worsen restless legs. And treatments, there are medications. So there's dopaminergic agents, lifestyle, calcium, magnesium, or iron supplements can also help with restless legs. So I'm going to go back a little bit to the cognitive behavior therapy because I want to just sort of demonstrate like how effective it is. This was a meta-analysis that I conducted in 2016. So we actually looked at about 750 people who have been diagnosed with cancer with insomnia. And we were able to improve their sleep efficiency. So that's how consolidated your sleep is, how much time you spend sleeping in bed versus time you're awake. We were able to improve that in the CBTI condition by 15.5% relative to 6.1% in the control. We were able to reduce the amount of time it took for people to fall asleep by about 20 minutes compared to 8 minutes in the control group. The amount of time they spent awake during the middle of the night was reduced by 30 minutes compared to 13 minutes. And they actually were rating their insomnia severity as much improved. So we were able to also demonstrate that these effects were durable up to about 6 months. So not in cancer, but in the general population, they've done comparative studies to look at the comparative efficacy of CBTI to medication. And what they find is that they're pretty equivalent in the short term, but the long-term thing is the kicker because they outperform medication in the long term. Because medication, as soon as you stop taking it, usually your insomnia comes back. Whereas with these, you're changing behavior and you're changing cognitions. So this is a more durable intervention, and you don't experience that same sort of relapse that you would with medication. So I want to end with some sleep better tips for you guys. So what can you do now to get yourself sleeping better? So the first one, as I mentioned, with sleep drive. You want to wake up at the same time every day. So regardless of whether it's a weekday or a weekend, regardless of how much you slept, at the same time, wake up at the same time, regardless of how many hours of sleep, including weekends. And because we really want to prime that circadian rhythm to shut off its production of melatonin and promote alertness, we want to make sure that we get morning light exposure of at least 30 minutes within 1 hour of waking up. So, you know, getting up and keeping the house dark and stuff like that, that's only just going to prolong the time you might feel that sort of grogginess, that sleep inertia in the morning. So waking up at the same time is really important, and getting light first thing in the morning is also very important. I've done other research looking at light boxes and using those first thing in the morning. And it actually produced durable improvements in fatigue. So people were feeling better getting this light and using it. They were using it daily only for a month, and they were able to demonstrate that it helped with their fatigue. The other thing would be because people with insomnia tend to kind of keep themselves really, really busy during the day, and then they find that these thoughts kind of come flooding in when they're trying to fall asleep, dedicating some sort of like clear your head time earlier in the day. So setting some sort of timer and saying, okay, you know, what do I have to do planning that project that I want to do? What am I worried about? You know, how am I going to resolve this issue that I'm having at work, or whatever it might be? Problem solving, planning, worrying earlier in the evening. And then if it does reoccur later on, just remind yourself that you've got a plan, and that, you know, even saying I'm going to deal with it in the morning, right? But not using that time in the evening to deal with it. The third one out of 5, my sleep better rules would be to establish a 90-minute buffer zone before your intended bedtime. So each of you can kind of in your head think about what your sleep schedule might be based on your total sleep time. So if you normally wake up at 6 o'clock in the morning and, you know, you're a 7-hour sleeper, that would bring your target bedtime to about 11, right? So then your buffer zone would happen about 9:30. So you've got this window there. And in this 90-minute window, you want to prepare yourself physically and emotionally for sleep. So not using backlit devices is especially important, because these backlit devices, even if you have them on night mode or you're wearing blue blocking glasses or whatever, it's still promoting that arousal and engagement with your devices. So doing something in dim light that's sedentary, pleasant, and relaxing in this 90-minute period before bed is really important. The fourth one is not spending time in bed trying to sleep. People will convince themselves that, okay, well, at least I'm resting. You don't actually want your bed to be associated with rest. You want your bed to be associated with sleep. So rest can be on the couch, but sleep should be in bed. So if you don't find yourself asleep within about 15, 20 minutes, 30 minutes at the latest, if you know you're thinking about things, just get up and do your thinking somewhere else. Do something pleasant, relaxing, non-stimulating, in dim light. Don't get on your devices in the middle of the night. That's the worst thing to do. And then when you find yourself sort of like nodding off again, then go back to bed. You don't want to fall asleep on the couch or in your chair, because then you're just associating your chair with the place that you sleep and not your bed. Right? So your chair is the place that you relax, but you want your bed to be the place that you fall asleep. And the last one would be, the worst thing is really stressing about the effects of poor sleep. The best thing that I hear people say to me is, all right, you know what? If I don't sleep tonight, I'll sleep tomorrow. Right? It's not a big deal. And that is the best thing to do, because your body has this homeostatic mechanism where, you know, more sleep is followed by less, and, you know, it balances things out. It's only when we start to get anxious and we worry about it and we stress and we try and like go to bed earlier and we, you know, that actually makes it more likely that we're not going to sleep. We can also really emphasize our ability to cope with the effects of poor sleep. So a lot of times people will cancel their activities that actually make them happy because they're not feeling particularly bad sleep. But that's, again, one of the worst things you should do, because, you know, going out and doing those things that you enjoy doing can actually make it easier for you to get through the day and make it easier for you to fall asleep that following night. So it's kind of decatastrophizing the effects of poor sleep. So there are some additional resources that I recommend, and both of these are written by Canadian authors. One of them is Queen's University Professor Judith Davidson. The other one is out of Ryerson, Colleen Carney. Both of them are kind of like self-help books that kind of go through the cognitive behavior therapy intervention that I've described, that the research is the strongest for. So both of those would be good resources for anybody who wants to explore this a little bit more on their own. And lastly, just to make you guys all jealous, this is a picture of an iceberg. And we've had unfortunately, not a great iceberg season this year, but typically we get some really good iceberg beasts around, and it's just, coming from the prairies as an Alberta girl, I just think icebergs are amazing. So I wanted to end with a picture of that and say thank you for listening to me. I know I could talk about this for a long time, but really what's more important is for me to be able to answer any questions you have right now.